Good morning, everybody. Dr. Mukesh has covered very well how to calculate IOL power in simple and complicated cases. So this morning I will be presenting in this IC course. Once you get IOL, post-operative surprise and decided to do IOL exchange. So there are certain indications for IOL exchange. One of them is refractive surprises, unhappy multifocal IOL patients, damaged optics due to neo-YAG laser, and many others like subluxated, dislocated lens or decentered lens. So what should be the time for exchange of IOL? Once you have decided to exchange the IOL, it should be done as early as possible because with the passage of time, capsular fibrosis and shrink wrap effect goes on increasing. So once you decided when the bag is in the IOL, the integrity of the bag is essential. The bag can be reopened by injecting viscoelastic into the AC and successfully dissecting the partially open bag. So main idea that bag should not get damaged, jonule should also remain intact, and PC should not get tear. So sometimes it is difficult to elevate the anterior capsular axis from the anterior surface of the IOL. So surgeon can create a cleavage plane by sliding a thin spatula underneath the edge of rhexis. In this maneuver is not successful due to strong adhesions. The edge of the rhexis can be delicately raised by using 25 or 30 gauge needle in a bevel position. So main idea, once the rhexis margins get stick to the IOL, it should be separated gently. So we try to cut the basically adhesions between the anterior surface of the lens and the rhexis margin. Then viscoelastic cannula can be inserted. Once you dissected the anterior rhexis margin, inserted under the rhexis edge and the bag opened by injecting more viscoelastic. So viscodissection is done in all the quadrant. IOL should be separated all over. So this is the standard protocol which is being followed. So how I do IOL exchange in my practice? Once I open the bone, I allow the anterior chamber to get collapsed. So some additions between IOL and the capsules get break. And then I inject the viscoelastic in the chamber and do IA, irrigation aspiration. Because of the turbulence of the fluid, some additions further get broken. Try to create cleavage between optic of the IOL and the posterior capsule by injecting viscoelastic. After injection of dispersive viscoelastic in the bag, I gently try to tease out one haptic out of the bag. Once one haptic is in the anterior chamber, we inject more viscoelastic between optic and posterior capsule and try to prolapse whole of the IOL in the anterior chamber. In some cases, when there is a strong adhesions of the haptic with the capsule in the equator, then we cut the haptic of the IOL and we take out and leave the haptic in the bag itself. So how we explant the IOL once we have separated IOL from the capsule or from the equator. So we bring the IOL in such a position that optic-haptic junction is near the main wound and fix the IOL with a chopper or micro grasp and with a vanna start cutting the IOL in the proximal optic-haptic junction. So basically, when I explant the IOL, cut the IOL, I do not use any instrument because you never know when IOL will be damaged, and even intraoperatively also primarily you need to explant the IOL. So I cut the IOL or exchange iron only by using varnas and simple chopper. So when you start cutting the iron, always take small bites with varnas to avoid the tilt of the iron. Always make sure that cutting is in the single tray, and while cutting iron, apply counter pressure from the chopper, as I will be showing in my video. So this is a basically picture. So how we should. So this is the varnas is near to the main wound, and this is another. This opposite end we should apply chopper. To apply the counter pressure. So less power will be required for cutting of the iron. After cutting the iron, grasp one of the haptics which is near the primary incision with a macpherson and explant first half of the iron. It should come out easily through a 2.8 millimeter wound. If you are finding a problem in taking out the iron from the 2.8 millimeter incision, don't put any pressure on the wound. We may easily enlarge the wound up to 3 millimeter. To avoid the damage of the wound configuration and descent detachment. Rotate the other part of the iron so that now the second haptic is near the primary incision, explant it in the same manner. Iron heart should always be preferably explanted by holding the haptic, because once you hold the haptic, the rest of the part of the iron follow it and comes out very easily. So what are the basically possible complications of this explantation of the iron? Main problem is the sealing of the wound. So why sealing problem is there? So I told you earlier, once we try to pull the iron from the smaller wound, there will be damage of the wound configuration and stretching of the corneal lamelles. So always, once you are finding the problem, enlarge the wound slightly and take it out easily. And again, there is a descent detachment, endothelial decompensation, because when we do the manipulation, there is a possibility that we may damage the endothelium. So we should use a good viscoelastic dispersive like viscot to coat the endothelium. And iris trauma, posterior capsule tear. This is a very dreaded complication while explanting the IOL. So we should always be ready with the 3-piece IOL. In case there is a not able to protect the posterior capsule, then we should do the good vitrectomy and we should implant the 3-piece IOL in the sulcus. Journal diagnosis, vitreous loss, and there is of course increased risk of infection. So as I told, always use a good dispersive viscoelastic like viscot to protect endothelium and push the vitreous back in event of tissue tear. So what are the limitations of the procedure? So it's a difficult in hydrophobic IOLs because of tendency to stick to the posterior capsule. So once you decided to explant the IOL, it should be done as early as possible. And very difficult after fibrosis takes place. If exchange is very difficult due to fibrosis or any other region, we should abandon the procedure and go to enhance the with the excimer laser or a piggyback IOL implantation. So this is the case of the toric IOL. In this case, we implanted the Indian toric IOL, but we were not getting the desired result, even the lens was in a proper position. So finally, after 15 days of the surgery, we decided to explant the IOL. It's a hydrophilic IOL. It's very easy to take out hydrophilic IOL. Even in hydrophobic also, after 15 days or till 1 month, there is not much of the problem. So I am trying to rotate the nucleus, try to rotate the IOL so it gets free in the bag. Should be done very gently, so there should not be any pressure on the jonules or on the jonular dialysis or some excessive pressure on the posterior capsule. Once you rotate the IOL, and create a cleavage between the posterior capsule and the lens, you inject viscoelastic, so posterior capsule get pushed and the lens comes forward. If you are not experienced, in explanting the IOL or not comfortable, then it should be done under block. In this case, I am explaining it under topical anesthesia only. So one by one, I have taken out the haptics of the IOL. See, I am using the simple spatula. But you see there is no counter pressure, so lens is getting slip. I am not getting proper hold. Now, just after using a single chopper, so cutting of the IOL is very simple. I am following the same trick, and in a single sitting I am able to cut the IOL. Once you cut the IOL, bring haptics near the wound and pull it with the make person. And it comes out very easily from 2.8 mm incision. Then again, rotate the remaining half of the IOL and bring haptic near the wound. If you are finding some problem in pulling out, then some counter pressure may be applied from the side port. Now we are implanting the toric ion of Alcon in this case. I will mark the axis 170 degree. It's very important to take out viscoelastic, not only from the antechamber but from the behind the lens. Because if you do not take out the viscoelastic, then iron may shift the position, and 1 degree shift causes 3% less effect. And make sure the chamber is formed on the table itself.